Origin, SpaceX, NASA, and many other tech firms. Today we're going to be performing spine surgery for you live. It's being broadcasted live so you can participate in watching the surgery and asking questions. All of our surgeries at Deuk Spine Institute are broadcast live, unedited. We're the only facility in the world that does this. There are live surgeries broadcast one at a time, here or there, other places, rarely. But Deuk Spine Institute has been broadcasting our surgeries live for 7 years, since we first started operating in 2014. Through our audiovisual system that allows the viewers to watch exactly what the surgeon sees through what's called first-person view or third-person view, as will be the case today. Depends on the surgery. And we also let you see the endoscopic view, the x-ray view, and if we use a microscope, the microscopic view. It's a fully integrated audiovisual system for the purpose of recording these surgeries in real time, multimodality. So the viewer gets the absolute best experience in terms of visualizing and hearing what's going on in the operating room. As a matter of fact, I've often said, when I was a resident training in neurosurgery, our view of what was happening during the surgery was very limited, because surgeons usually stand on both sides of the patient. So you have the primary surgeon, the assistant surgeon, and if you're a lower level resident, you're not assisting in the case, it's usually the chief resident. And so unless you're the chief resident or the attending, you can't really see what they're doing. You just kind of stand in the room and soak in the sounds and sights, but your view of the operative field is extremely limited. So the system we developed here at Deuk Spine Institute, the audiovisual system, allows the viewer to see everything the surgeon sees. And it's really exceptional. It's one of a kind system. And of course, we've been broadcasting with it now for 7 years and recording all the surgeries done here. And there's over 1,000 surgeries. So we can go back at any time and study the surgery and learn from it, or other people can study it. Well, today we're going to be treating a patient who has a herniated disc in their back at L5-S1, and it's off to the right side, and this patient has back pain and right leg pain. Now, what are her options for treatment? One option would be a fusion of L5-S1. There are other surgeries that some doctors would do, like a microdiscectomy or a laminectomy, but they don't work. They don't fix back pain. They only unpinch nerves and fix leg symptoms. So if you want to cure back pain and leg symptoms, you either have to do a decompression and fusion with instrumentation, that screws and rods, cage, or you need to do the Deuk laser disc repair, which is what we're about to do. The Deuk laser disc repair is done outpatient. It's a bloodless surgery, basically. We lose a couple of drops of blood, and the pain for the patient afterwards is so minimal, they take Tylenol. There's no narcotics like you would take with fusion. Most fusions are done in the hospital. This is being done outpatient from a surgery center. So it's a much better surgery than a fusion. Okay, our patient's awake. We're going to get started. This is Dr. Deuk. Can you hear me? We're going to get started, okay? It's important you lay still. I'm going to give you some numbing medicine. You'll feel a little stick in your back, a little ouch, and a burn. If you have pain, just say ouch, okay? But don't try to move around. It's important you lay still. How are we doing with the positioning of the head and neck?
I asked her just
Yeah.
a few minutes ago to make sure that she was okay.
Yeah. So, Luis, we had a couple of patients that their neck was probably extended a little too much on Tuesday, so they had a little discomfort.
Okay.
I'm sure it's just temporary. But you either need to raise the body higher and drop the neck a little bit, or you need to just drop the neck without raising the body. So
Yes, sir.
I'm not sure what we did different on Tuesday, but whatever it is, we need to fix it. Okay. All right. I'm just feeling around. I'm feeling for the right place to go in and place my needle. You're going to feel a little stick and burn. That's normal, okay? Don't freak out. So I'm just putting a little bit of numbing medicine on the skin to make it feel better for her when we make the incision. All right. Now, I don't know exactly where I'm going to be placing my needle yet. That's something that I have to use the x-ray machine to figure out. Needle down, 5 cc's injected. All right. So I may have to adjust the final location of where I enter the patient. We're going in the flank, and you know, I got to look at where, just, you can leave that, but I got to look at where we are entering. Whenever you're navigating in the human body for a medical procedure, there's always an entry point and there's a target point. And the goal is to go from the entry point to the target point safely without damaging any tissues, organs, vessels, etc., that could be in the way. So same thing for this procedure, the Deuk laser disc repair. I need to go from the outside world where I can bring my laser in and scope in to the target, which is the L5-S1 disc. Let's go lateral. Now, the Deuk laser disc repair surgery that we're doing today is a very unique surgery. What that means is there's no other surgery in the world or on earth like it. It's the first of its kind. It's the first surgery ever designed to target the actual cause of back pain, neck pain, thoracic pain. Basically, spine pain comes from one or two different things that could be causing the pain. The most common is the disc, a herniated disc specifically, the annular tear within the herniated disc, or the facet joints. Those are the two most common causes of neck or back pain. That's where I am. So this procedure you're watching right now targets the disc pain, the source of disc pain. So a lot of doctors don't even know that the disc can cause pain. As a matter of fact, they don't believe the disc can cause pain because they don't understand the pathophysiology of back pain and neck pain, which is why there are so many people living with back and neck pain, because the doctors don't know how to fix it. You understand? They don't know how to fix it because they don't know where it's coming from. At Deuk Spine Institute, we discovered where it's coming from. And in every patient, it is a little bit different, but not that different. It's either the disc that's herniated, or discs, plural, or it's the facet joint, sometimes the sacroiliac joint. But about 90% of chronic back and neck pain comes from either a herniated disc or a facet joint. Okay? And we can fix both very easily. Are you awake? Shot. So I'm just entering the foramen on the right side. And the foramen is, there's something in the foramen, two things that are very important. One is the nerve that's leaving the foramen, which you don't want to injure. And the other is blood vessels that are entering the foramen. Let's just say entering. So I'm a little low, which is okay. It's better to be low than high in the foramen. You never want to be up high. So I don't know if I'm actually going to be able to get to the disc. Let's see. I can kind of feel the herniation there. Shot. I'm a little lower than I probably want to be. And it's not in a bad way lower. It's just we're a little bit too low. So I'm going to move up about a millimeter or two. And to do that, I back up. And I will redirect higher. Shot. That's better. And then I will pass higher in the foramen. Are you comfortable, Shot? Are you comfortable? All right. Let me know if you have any pain in your leg, okay? Pain down the leg. That's what I'm interested in right now. Shot? And you have, there is perfect positioning. So you see how I redirected, and I'm very happy with our, the tip of the needle and our trajectory. The trajectory you can map out by looking at the shaft of the needle. You can see where it's going to go. The tip of the needle is special. It is beveled, and it is a special needle that allows me to navigate. Okay, we're about ready. So I feel the herniation at the tip. It's firm. I'm going to pass through it and into the disc. Shot. Okay, so we are inside the disc. I went through the tear and the herniation. So this procedure is unique in the whole world. It's the only surgery in the world that actually fixes the source of back pain and neck pain when it comes from a disc herniation. And that's because I am fixing the annular tear. Nobody cares about the annular tear. Nobody ever talks about the annular tear. But I discovered it's the annular tear that is the cause of back pain, neck pain, and even arm symptoms. It's the inflammation within the annular tear. Are you okay? Have you ever watched one of these surgeries done on the internet? No? Huh? No? All right, well, if you did, you'd know what's happening next. All right, well, how much pain did you have there? I can't hear her. What's the worst it went to? I can see her arch her back. What's the highest number, 1 to 10, 10 being the worst pain of your life? So she has a big tear. A lot of the dye just leaked out.
4 or 5.
Okay. Is that where you typically get your back pain?
Yes.
All right. So we're going to put you to sleep. When you wake up, we'll be done, okay? All right. Sweet dreams. I want you to count from 1 to 100 out loud. Count from 1 to 100 out loud. I want to hear your numbers. Keep going. You're doing great. About 5 out of 10 concordant, yeah. So her primary problem is not back pain. It's actually her right leg pain. And but she does have back pain as well. So we're going to be fixing the back pain and the right leg pain. They're both coming from the annular tear and herniated disc. The herniated disc is actually a piece of nuclear material from the center of the disc that's pushed out through the tear within the wall of the disc. The wall of the disc is called the annulus fibrosus, and it's about 1 centimeter thick in most places. It has a different diameter depending on, I'm sorry, not diameter, but a different thickness depending on where you are, like the sides of the disc versus the back of the disc. And the back sides of the disc are pretty thin. So, for those of you who know spinal anatomy, there's a ligament that runs down the back of the spine, down the back of the vertebrae, I should say. Not the back of the spine, but the back of the vertebral body. And the disc is located between the vertebral bodies, like a little hamburger, like a piece of meat patty stuck between two buns, the buns being the vertebral bodies. And there's a certain region of that disc that is most susceptible to injury and herniation, and that is the posterolateral areas, right where the nerve exits the neuroforamen. And the reason for that, let me know when you're ready. Is she ready for some stimulation? All right. The reason for that is because the posterior longitudinal ligament runs down the back of the vertebral body and disc along the center of the disc. Okay? But what happens is the posterior longitudinal ligament reinforces the annulus and back of the disc where it is. But just off to the sides of the posterior ligament is the weakest spot of the disc because there is no posterior longitudinal ligament supporting the back of the disc there, off to the side. So it's an area that's commonly torn and injured. And then, of course, just regular activities like lifting, bending, twisting puts pressure on the nucleus and the disc when you load your spine with normal biomechanical loads, and that pushes the nuclear material against the walls, the inner walls of the annulus fibrosus. Shot. So when you bend and twist and lift and play sports and do stuff, your bones are moving and the disc is a cushion, and that when you lift something or bend, you're literally pushing down on the nuclear material, and that makes the nuclear material want to squeeze out, but the annulus fibrosus blocks it like a wall, a circular wall. Well, if you have a tear in the annulus fibrosus, the annular tear, which is the beginning of every herniation and every disc problem ever, that tear lets the jelly squeeze out through the tear because it's a path of least resistance. Otherwise, the jelly can't get out of the disc unless there's a tear. So it pushes out through the annular tear. And then it just sits there within the annular tear, and it causes inflammation. And that inflammation is what causes back pain or neck pain or thoracic pain from a herniated disc. Now, I'm telling you this, but you will not hear this from any other doctor. Why? Because they don't know this. Literally, we discovered this here at Deuk Spine Institute. It is the basis of back pain and neck pain from a herniated disc or discogenic pain. You talk to most neurosurgeons, they'll laugh. They won't even take you serious if you even talk about curing back pain or curing neck pain with surgery. They don't believe it's possible because they don't know how to do it. Now, it does work when you do a fusion of the right discs. But look at Tiger Woods. In the news yesterday, Tiger Woods had a 5th back surgery. Why? He had 4 back surgeries to fix 1 disc. He had 3 microdiscectomies, which don't work for back pain, by the way. Remember, I've told you that. He had 3 of them. I mean, I don't know who to blame more, Tiger Woods or his doctors for doing 3 surgeries. And then finally he had a fusion, okay? And the fusion worked for a while, but now he's back again with another disc herniation. And they did another microdiscectomy. Stupid, okay? Just stupid. This surgery is in place of a microdiscectomy. Microdiscectomy doesn't cure back pain because you're not fixing the annular tear. All right. So Tiger Woods is going to continue to suffer and continue to have more surgeries like everybody else that doesn't come to Deuk Spine. Yeah, I said it. It's true. If he would have came here the first time, we would have fixed his back with 1 surgery. And he would be back. He wouldn't have lost 10 years and $1 billion. But what can I say? I'm not good at marketing. We're just good at curing pain. All right. So when I put this thing in, she's reacting a little bit. Shot? Okay. Let me pull this dilator back just a little bit. The dilator is fine where it is, but if I am banging the tube in over the dilator, why would you not have that already on the field?
The reason is I have 2, and I just wondering.
She's moving around just a little bit. Shot. Lay still. Everything's okay. I'm not sure what you're saying, Luis. Shot. Well, what I was getting at, see that? See how the dilator advanced with the tube? Well, I'm talking to our audience.
Oh, I'm sorry.
Sometimes, I already know you know. Sometimes they'll give you a little bit of tissue that gets stuck between the dilator and the tube, and it'll trap the two and kind of weld them together, so to speak. At least functionally weld them together. And then they move together, and you don't want the dilator going any further. So I have to stop and pull it back a little bit. Let's see where we are. Shot. I think that's where our tube is, and that looks good. So I'm ready to take the dilator out. Take it, shot, and get the fluoro out. So we're inside the disc. I use a technique that I was taught by Dr. Anthony Young, and there's 2 different fields of thought on this for endoscopic transforaminal surgeons for the lumbar. One thought is start in the foramen and go down to the herniation. And that's Dr. Who was it? So Martin Knight? I think it was Dr. Martin Knight. He was a proponent of that. I am not a proponent of that technique. Never, 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 never. Very dangerous. I'm a proponent of the Dr. Young technique. Dr. Anthony Young developed a technique where you start with the end of the tube inside the disc. It's called intradiscal, and you back yourself out. Hey, why is that fluoro so close to him? Come on, pull it back, please. And turn it away just a little bit. There you go. That's good. Okay. So, thank you, Luis. So the safest way to do endoscopic transforaminal surgery like this is to always start inside the disc. And there's an added benefit which nobody's ever talked about. Dr. Young never talked about it, but it is a benefit. And that is, you're actually, when you go transforaminal into the disc, you're actually going through the herniation. So, you know, for a while I could never figure out why was the herniation inside the disc? How did it get back in there? But it actually is obvious how it got in there. We just passed the dilator through the herniation, pushing it back into the disc. So starting inside the disc is safer because you're not anywhere near the nerves or arteries in the foramen, but it's also better because you actually shove the herniation back into the disc and then you can take it out safely. So two very good reasons to do the intradiscal approach, which I learned from Dr. Tony Young out in Phoenix, Arizona, many years ago when I first started doing these surgeries. All right, there's the tear right there. You see it? All right, our visibility sucks because we have some air bubbles and schmutz. So I'm going to wipe that. It's pretty amazing, huh? I mean, are very few endoscopic surgeons in the world that do lumbar endoscopic surgery. I'm the only one that does cervical at this point, and I'm the only one that does thoracic disc herniations. But there's so few surgeons that do this, yet it's so much better than open surgery. Leagues better. I mean, literally, crazy better. And just for those of you who think, I do this surgery because this is all I know how to do, you couldn't be further from the truth. I have been trained in very complex spine surgery, the most complex you can do. You know, instrumentation, multi-level, fusion, deformity correction, reductions, inner body, posterior, combined anterior and posterior, osteotomies. I do it all. I've been doing it all for 24 years. I'm actually one of the best in the world at doing it, which is why we do it outpatient here at Deuk Spine, and they can't do it anywhere else outpatient with multi-level fusions. However, that said, I have the ability to do any spine surgery on a patient. With my training, I can do anything. But I choose to do this, and the patients choose to do this because it's better, far better than the open surgery. Much faster recovery. Literally an hour to recover versus weeks of recovery for open back surgery. People can go back to work the next day with this surgery. Whereas with open back surgery, it takes them weeks, if not months, to go back to work. So getting back to a normal life much faster with Deuk laser disc repair, endoscopic spine surgery you're watching. The success rate curing pain is 98% now with the Deuk laser disc repair. Whereas with open back surgery, you'd be lucky if you get 50% chance of pain relief, 50% pain relief. That's what most surgeons will tell you. Go talk to them. What's the elimination of pain success rate? You know, why are you having surgery anyway? Don't you want to get rid of your pain? I mean, that's why patients go have surgery. They don't have surgery to make their disc look good. They don't have surgery to have metal put in their body. They don't have surgery to line the surgeon's pockets with money. They have surgery because they want to get rid of a problem, a symptom, or a finding on exam like weakness. So the whole notion that we do surgery for anything other than make the patients better is crazy to me. But there's a lot of surgeons that, you know, are happy to do spine surgery and not have great results because that's what they're told to do. And they're doing what they've been told to do, even though it doesn't work very well, okay? Even though there's a much better option, like endoscopic surgery that I'm doing. So people need to wake up and be better consumers. You know, the old days when they did sinus surgery, they used to peel the skin off your face and go in and drain your sinuses. That's horrible. Now they do it endoscopically. Why would you ever get your face peeled off to get your sinuses fixed now when you can just do it endoscopically, outpatient, be home an hour after your surgery? So there are advances in every field of medicine for less invasive, faster recovery, and better results. And this surgery you're watching right now is the best results by far in the world for treating back pain, and it is the fastest recovery of all spine surgeries in the world, and it's the fastest return to work and normal life than all spine surgeries. And it's the cheapest, to be honest with you. So why would you not do it? Well, I can tell you why surgeons don't do it. It's because they don't know how to do it. It takes special equipment that they don't have. It takes special training that they don't have. And they'll never get it because they have to literally stop their practice for a year and come work with me for a year to learn how to do it. And so most doctors don't want to give up their practice for a year and come and train on a new technology. They don't mind if they can learn it on a weekend, but this kind of surgery you can't just learn on a weekend. So they need to dedicate themselves, and there are very few surgeons in the world that will dedicate themselves and take a year off of their life to go train with a surgeon like me. And I don't blame them, to be honest with you, because all their colleagues are doing fusions and metal, and you know, they do it and they get away with it. It's the normal, right? It's norm. So they're just doing what's normal, the expected. Unfortunately, that's not what's best for patients. So patients are the only way, when they demand better, that's the only way the better will happen. Okay? So patients really need to be more active or proactive in making sure that they get the very best care. It's really unfortunate that doctors don't take that responsibility themselves. You know, I do that for my patients. I had a patient in my clinic the other day, yesterday. She had a sacral fracture. Okay? Now, a sacral fracture is a complicated fracture to fix. And this patient had an unstable sacral fracture. So she clearly needed a surgery where you fuse the lumbar spine, sacrum to the iliac, to the pelvis, basically, with screws in the iliac wings. Now that's a surgery that I have not done. I've not done screws in the iliac bone, but I could probably do it. I could probably wing it. I'm sure I do a good job. But the reality is I've never done it before. And that's what she needed. She needed a surgery that I don't do. So I have a choice. Either to keep the patient and keep the money, I just do what I can do even though it's not what's best for the patient, or I send the patient to a surgeon who knows how to do that surgery and does it well. What do you think I chose to do? I sent the patient to a surgeon who knows how to do that surgery, has done it before and does it well. That's what I did. I referred the patient. That's what spine surgeons should do. If they don't know how to do endoscopic Deuk laser disc repair, they should be referring their patients here until they do learn how to do it. I do the same thing as a neurosurgeon with patients with aneurysms, AVMs. I don't treat those conditions regularly. I'm not the best surgeon in the world for my patient to have aneurysm surgery done. Sure, I know how to do it, and sure, I could probably do a good job, but I haven't done an aneurysm surgery case in years, and I'm not up to date on the latest treatments. So the truth is even though I can do it legally because I'm a neurosurgeon, even though I could do it because I have the equipment, the truth is I'm not the right person to do it because my experience is not proper, and I know the patient would get better care elsewhere. So I don't do those surgeries. It's about knowing what's best for your patient and willing to do what's best for your patient. So what I'm getting at is spine surgeons that do fusions for these disc injuries should stop fusing, stop putting in artificial discs, because those surgeries don't work very well. And they should start referring their patients for the Deuk laser disc repair because it's a much safer, faster, and better surgery than anything they're doing. But they won't do that for several reasons. Most importantly is, I guess they just don't want to lose the business. But I have to say it's not all their fault. Look at that tear right there. You see that? I don't know if you can see it. Right there. I'll stick the laser in and show you. But this is the annular tear. The annulus itself is white and it's fibrous. And so you can see it right there is a tear. And through that tear, the jelly from in here squeezed out and created inflammation. The jelly is stained blue. That's why we use a blue dye, so you can see the nuclear material. But you see the tear there? And the nuclear material wedged inside? That's what I'm debriding. This is an annular debridement. It's not a discectomy, it's an annular debridement. So it's the only surgery in the world that does an annular debridement. And it's the only surgery in the world that can actually cure back pain without fusing and putting an artificial metal or plastic in your body. Because it's the only surgery in the world that addresses the annular tear and debrides it. The actual annular tear causing pain. Now there are other annular tears that are not causing pain that this patient has. But it's my job before surgery to figure out which herniated discs, which annular tears are actually causing symptoms. And that's the art. And it's not guesswork, I can tell you that right now. It is a science. We have it down to a science at Deuk Spine Institute, which is why our success rate is so high. If there are 2 discs that are causing the patient's back pain, and I fix only one of the 2, they will not have all their back pain gone. They'll only have 50% maybe of their back pain gone. Okay? So for me to have 95% elimination or 98% elimination of back pain with Deuk laser disc repair, which is what our average is, you have to make sure you're getting all the discs that are causing pain. Otherwise, the patient will be done with surgery and they'll still have pain. So it's important to get the right discs. And that's what we do preoperatively. You don't do that in the operating room usually. You just do that before surgery. Now sometimes I'll do a discogram in the operating room to confirm or rule out, so rule in or rule out a herniated disc as being a source of pain. And that's why you always see me doing discograms. I like to confirm. Plus I need to inject the blue dye anyway to do the surgery. So the only way to inject the blue dye is to do a discogram. There's part of the tear right there. You can kind of see when things move. You can see a tear in the annulus. And the blue stuff is, again, nucleus pulposus. That's the jelly from the center. The hydraulic jelly. Yes, you have a question.
Yes, one of our viewers from Facebook is wondering, why don't more surgeons broadcast their surgeries live?
Why don't more surgeons broadcast their surgeries live? The real reason is they're afraid to. Surgeons make mistakes in the operating room all the time, and they don't want anyone to see those mistakes. So the reason I broadcast live is, well, if I made a lot of mistakes like they do, I probably wouldn't be broadcasting live. But I've done so many of these surgeries, I'm very comfortable with the anatomy and the technique that I'm comfortable broadcasting live, even if I make a mistake, which I don't make mistakes. It's just hard to explain. It's really, that's what it comes down to. Plus it costs a lot of money to buy this equipment, and most surgeons don't want to spend the money because they don't feel there's a need. It's really not the standard for surgeons to broadcast their surgeries. We do it because we want the public to see the truth about spine surgery, you know. I want people to see the truth about what really happens in the operating room, what really happens in surgery, what happens after surgery, how the patients do. You know, we think that I believe there's so much misinformation out there about spine surgery and spine care and causes of back pain, neck pain, diseases and treatments. We want the world to know the truth. That's why. It's my mission, my educational purpose in life. So why don't other surgeons do it? Because it's not their purpose. It's not their mission. It's not their goal. Their goal is whatever their goal is, you know, just to do surgery or take care of patients, but they don't want to educate. Educating people is not normally something surgeons do. It's something different. It's, you know, there are educating physicians. They usually work at the university. They're educating other doctors. But the truth is that doctors don't need necessarily, they're not the only ones that need to be educated. People do. Patients do. People suffering with pain need to be educated, even more than doctors do. Because doctors, I've found, and by the way, there are doctors who watch these surgeries and learn. So it's not just lay people watching my surgeries. It's also doctors, surgeons from around the world. And but I just feel that the message and the education needs to target everyday people who are called stakeholders, you know. Basically, they have a vested interest in knowing the truth about back pain, neck pain, surgery, what the options are. You know, surgeons, it's good to educate surgeons too, and anesthesiologists and other doctors, but the most important people in medicine is the patient. So my goal is to educate the patient. And so that's why we broadcast. I don't broadcast live just to educate doctors and nurses. I broadcast live to educate anybody that has an interest. And most of those people are going to be non-doctors and non-nurses. So we're here as a learning resource because I want people to know the truth about what's available. That's why. I don't know why other doctors don't. They don't have the interest, they don't have the skills, they don't have the money and time. I mean, there's probably a lot of reasons. There are occasionally broadcasts of surgery done. For example, when I first learned how to do endoscopic spine surgery, I watched a live broadcast from Korea, South Korea, one surgery during a meeting. And they did a anterior cervical discectomy. So I've seen live broadcasts, but they're extremely rare. And it's mostly because, you know, surgeons truly do make mistakes quite often. And they don't want their mistakes seen. So even though these surgeons in Korea had the capability to do broadcasts live because they clearly had done it, they chose not to. This is the tear, by the way, that's causing all the pain. And it's just, this is the outside of it. This is like, we're almost done. This is the last of the herniation and the tear. I'm almost done. At 12 o'clock is the epidural space with epidural fat. A little bit of foraminal ligament coming in at the top there. This is the back of the disc at L5-S1. This is the foramen and the posterolateral part of the disc herniation. Right in here, all this junk. That's all a herniated disc. And I'm just zapping it away with a laser. I don't know if I answered your question appropriately, but I tried. I can't speak for other doctors. Honestly, I just like educating people. I've been an educator ever since college. I understood things in a way that a lot of other people didn't, and I always appreciated teachers teaching me so I could learn things and understand them. So I wanted to share that with other people. I wanted to teach just like I was taught. I mean, where would I be if I wasn't taught all these things? I would be nothing. You know, I wouldn't be helping people like I am today. So I just feel like the more we can teach and learn with each other, the more we know, the better we can overcome problems, the world's problems, you know? And so I'm just trying to do my part. I don't get paid for this. I don't make any money for doing the teaching on broadcasting. I actually have to pay people out of my pocket to do it. But I just feel it's my duty. I don't know. It's weird. My calling, so to speak, because nobody else is doing it. I mean, if there were lots of other doctors broadcasting their surgeries, I probably wouldn't be broadcasting them because somebody else is already doing it, you know, and they don't need me to do it. But because nobody else is doing it, and I think it's something of value to society as a whole for educational purposes, that's why we do it. And I enjoy teaching. So I guess that's my answer. I don't know if that really answers your question. I explained why I do it, but I don't think other surgeons really share my enthusiasm of teaching and being transparent. Yeah, I mean, I guess you have to ask surgeons yourself. I don't know. I don't really talk to other surgeons very much. Frankly, I don't care much for them. They're mostly arrogant, egocentric, and selfish, narcissistic, many of them. So I have a hard time relating to them. They love going to meetings with themselves, wearing suits and ties and looking good and showing everybody their insignificant, pitiful research they do and rubbing each other's backs. And they always forget about the most important person in medicine, and that is the patient. So I don't have a lot in common with other spine surgeons and neurosurgeons. I went into medicine to help people. A lot of them go into medicine to help themselves. So I don't know why they don't broadcast their surgeries. Maybe they don't feel it's worth their effort and time. You know, maybe they're afraid of people seeing what they do. So I'm lateral in the disc. You can actually, this is just a little piece of herniation I'm just going after. But this is the annulus here. There's some herniation there. I don't think this is pushing on the nerve root at this point. I think we've gotten most of the herniation out. Right there, that pink wall, that's the end plate. That would be the end plate of L5 on the right and S1 on the left. Now you can see the annular fibers, and I'm just about done. I need about 1 minute and we'll be done. I'm letting my anesthesiologist know so that she can start to wake the patient up. We use propofol sedation and MAC, and we love propofol here because it's the very best medicine in the world for this application of putting people to sleep for a short period of time. And you know, people don't feel groggy afterwards. They wake up and they're bright and alert and they feel good. Whereas if you use some of the other sedatives, the old ones, like Versed, you know, it just has an effect on the brain for the rest of the day. And people are just tired and groggy. And I've had myself colonoscopy where I had propofol, and you know, I wake up and I'm like, within an hour I'm ready to go back to work. I love it. So I love that feeling of not being groggy and sleepy all day after a procedure. So we give it to our patients because it's better than Versed and fentanyl. Much better and safer, to be honest with you. Safer and a better recovery. But it costs us more money. We don't get more money from the patient for it. We still get the same amount of money. But we do it because it's the right thing to do. It's what's best for the patient. All right, we're done. Laser off. Now, let's see if we can see the nerve. Oh, there, finally you can see the nerve. Look at that white right there. You see that? Look at the dura. You see it? All right, that's what was pushing. The herniation right there was pushing on the nerve, and it's gone. Her primary problem was not back pain, it was more leg. But we got her back pain treated as well. Scope off. All right, let me show you. Let me show you how we did this. All right, Sean, you here?
Yes, we can see it.
So this is the middle of the back. Her hips are here. Her butt is here. Her thoracic area is here. And since it was her right leg, sciatica, that the problem, herniated disc on the right side, pushing on the right L5-S1 nerve root, we went in on the right side. And you can see the whole surgery is done through a tiny little cut. It's called transforaminal. And we did the surgery through a little cut, and we did it through this metal tube called a tubular retractor. Okay, so I'm going to show it to you. This is hooked up to a suction line, which we really don't even use, except right at the end. I'm putting pressure. You want to put some pressure here? Sure. The reason we put pressure is in case there's a little bit of bleeding in the muscle, you want to stop it by putting pressure. The only bleeding that will happen in the muscle is venous bleeding. You won't get arterial bleeding because there's very few arteries. It's mostly small arterioles, and by putting the tube in, sometimes you tear a vein and the vein will bleed. You won't tear an artery, you'll tear a vein. So veins have a pressure of about 10 millimeters of mercury. So they'll bleed into the muscle until a blood clot forms in the muscle that's 10 millimeters of mercury in pressure. And if you get a blood clot in the muscle, then it will dissolve over 2 or 3 months. and the hemosiderin released from the blood dissolving will irritate the muscle and cause muscle spasm and even scarring in the muscle. So after every one of these surgeries, we put pressure on the muscle to prevent the blood from leaving the vein until it clots off. And so once the vein clots off, which takes about 3 minutes, as long as the patient has normal platelet function and normal coagulation function, then they'll clot off in 3 minutes and there won't be any more bleeding into the muscle. So basically we're avoiding a blood clot in the muscle. An intramuscular hematoma is what it's called. Now most intramuscular hematomas are totally asymptomatic, but I had one patient who many years ago, before I put pressure after the surgery, he got a little hematoma in there. Nothing clinically significant. He went home, but he had muscle spasms for like a month afterwards, and he was just uncomfortable. So by doing the pressure, you avoid intramuscular hematoma, you avoid pain after surgery. And the patients take Tylenol, they come in the next day, you can push over here, there's no muscle spasms, no pain. All right, we did the whole surgery through this little tube. You see that? Right there, okay? Looks like a shake straw. It's 7 millimeters. So the incision is only 7 millimeters in diameter. It's beautiful. And you took the scope away. I was going to show them my scope.
Oh, I'm sorry. It's right here.
All right. Now, this scope was wounded, which is why we have it wrapped in a bandage. I'm just kidding. We wrap it because it leaks all over the floor in my shoes otherwise. And so the bandage keeps the water from getting on my feet. It's cold. So you can see how long the scope is. It's called a rigid scope. It's a rod lens scope. And it has a port for the fiber optic light or illumination. It's got a irrigation port. And then of course it has a lens here where you can put the camera. And this is the camera right here. We use a high definition endoscopic camera, okay? And then I do all my work through that hole. All right, let's see the incision so everyone can see it. All right, here's the incision. It's tiny. The whole surgery was done through that. We took no bone out of this patient's spine. You go get a microdiscectomy like Tiger Woods just had. He's got bone taken out of his spine. Horrible, bad. Of course, the surgeon doesn't say that to him because that's just how they do the surgery. So it's part of, you know, it's kind of like when we dropped the nuclear bomb on Hiroshima. We killed lots of innocent civilians that shouldn't have been killed. But, you know, it's like, well, why'd you do that? Well, we had to do it. We had no other option. Well, now there is a better option where you don't have to take bone out of someone's spine, called a laminotomy, facetectomy. You can actually leave all that natural bone and joints and ligaments intact. You go through a hole that's already there. And that's what the Deuk laser disc repair is. So Tiger Woods will be back in the operating room again. Pretty much guarantee it. If he would have came here, we would have fixed him the first time, and he would never be back in the operating room again. But he doesn't know about us. So he can't possibly come somewhere he doesn't know exists. That's the problem, is dissemination of information and knowledge. All right, blood loss, I'm going to call 1 cc, or 1 drop, basically. And no complications. This was a right L5-S1, DLDR, Deuk laser disc repair. Only done at Deuk Spine Institute. Okay, and I'll come and answer your questions, folks. So go ahead and type up your question right now, and we'll come and answer them for you. I'll be right there, Sean.
All right, everyone, thank you for joining us for the Postop Q&A. We have Dr. Deuk. He's about to sit down with us and answer some of your questions. If you do have any remaining questions after the surgery has been concluded, go ahead and type them in the chat now. Otherwise, I'm going to hand the microphone over to Dr. Deuk. We'll turn on the face cam. He'll answer your questions and also recap the surgery you just watched.
Sorry, Dr. Deuk here, and we're going to get this camera up and running so I can talk to you and answer questions for you. If you have a question for me about spine, back pain, neck pain, anything going on related to the spine, please feel free to type it in, whether you're on Twitter or Periscope, Facebook or YouTube. Type your question in. You could also email us questions at dukespine.com. and I'd be happy to answer them for you. So we just wrapped up our first surgery for today being January 21st, 2021, and it is a Thursday. We're here on the Space Coast of Florida in Melbourne at the Deuk Spine Institute. Our patient we just did surgery on, she had a herniated disc at L5-S1. It was off to the right side, and it was rubbing on the nerve going down her leg. Now, the herniation happens to be in the foramen, the neuroforamen, which is a hole on the right side of the spine, and that's the exact same hole we went through in order to take the herniation out. So, what I was saying earlier, for those of you interested, is, can you hold the mic for me? We should get a clip-on mic. All right, it may seem like we're winging it here, but we're not. We're actually professionals. So let me just show you. This one has roast beef on it still. This is the spinal unit. What the spinal unit is, it's a vertebrae, which is the white thing, the bone, and then another vertebrae below it or above it, and then the disc in between. That's the spinal unit. And you can see right here, this disc in the back here, this red thing is a herniation, all right? On the other side, you don't see the herniation. It's not there. This is normal, and this is what a herniation looks like, okay? So there's a hole right here where this yellow thing, the nerve comes out. That's called the nerve root, and it goes down your leg, and when the herniation either irritates the nerve root or pushes on the nerve root, that's when the patient will experience pain shooting down their leg. And that's because the nerve actually runs all the way down the leg to the toe. And so any kind of problem like pain in the toe, so if you step on a nail or you stub your toe, you feel pain down at your toe, well, that pain is transmitted by nerve fibers all the way up a cable that comes in right here and goes in and then goes up to the brain, okay? Inside the spinal canal right there. It travels up to the brain. So when you push on the nerve right here, you're basically capturing the fibers, the nerve fibers that go to all parts of the leg that nerve goes to. So what the patient experiences is pain down the leg, but there really is nothing going on in the leg except the nerve is being irritated or compressed right here in the neuroforamen. The Deuk laser disc repair is special because, as I was saying earlier, Tiger Woods, I guess, has one of these herniations causing back pain, and maybe his leg is irritated as well. The way every other spine surgeon in the world today treats this is they come in back here, okay, and they peel the muscle, which is sitting on the bone right here. They peel that muscle off to the side. Can you guys see that, Sean? Pretty good? What, blurry or what? All right, so the surgeon peels the muscle off the spine and then drills a hole right here in the bone. The bone right here is called the lamina. So to get a microdiscectomy done, which is what every other surgeon does, is they have to remove all this bone here, and then they have to work past the bone and get to the herniation. So what you're losing with that surgery is they're drilling this facet joint, which is one of your spine joints. They're taking that out, part of it, usually about 50%. And they're taking part of this bone out just to get down to the disc herniation to fix it. All right, what I do with the Deuk laser disc repair is I don't take any of your bone out, none of your ligaments. I come from the side like this and go straight into the herniation. So there's no damage to the spine whatsoever, which is why people recover in an hour and they don't have any problems later on that end up needing fusion. It's an incredible surgery. It works really well. And it treats not just the leg symptoms that a microdiscectomy treats, it also treats back pain. We do this in the neck too for herniated discs, so you can treat neck pain and arm pain. You can also treat headaches that come from the neck called cervicogenic headaches. All right. Did you read our first question? All right, we have a question. So Sean's going to read it. Sean's a little camera shy still.
All right, so we have a viewer on Facebook who's wondering, when comparing DLDR to ACDF, for example, how does the patient's overall cost compare when you think about the out-of-pocket price and the time off work lost to recovery? Is fusion always more expensive when you consider all the factors?
Great question. All right, so the question is, when comparing two different treatments for, do we have a ACDF model here? When comparing two different treatments, yeah, perfect, for herniated discs in the neck, okay? So what most surgeons will do is this surgery right here, okay? And, want to grab my mic again? Take note, what we have here is we have the spine, smaller vertebrae, right? So you can see the difference in size of vertebrae in the neck versus the lower back. There's a lot more weight on the lower back vertebrae from your whole trunk pushing down, so you need bigger vertebrae. In the neck, you need smaller vertebrae because you have less weight. You have your skull and you have your arms attached through muscles to the spine. So basically with an ACDF, the surgeon is cleaning out your whole disc, putting a plastic spacer and a metal plate bolted to the spine. That's an anterior cervical discectomy and fusion. That's the most common surgery done in the world for a herniated disc in the neck. When I do the Deuk laser disc repair in the neck for a herniated disc, I come in through the front endoscopically and I go all the way back to where the herniation is, and I have a tube in there, and then I can see the herniation and I zap it away using a laser. So there's no cage, there's no fusion, there's no metal and plate. It's all natural. I come out when I'm done and there's nothing there and the herniation's gone. So the question was, when you're comparing a fusion, ACDF, versus Deuk laser disc repair on the neck, what's the difference in price or cost to the patient? Great question. So that depends on the patient's insurance plan. If their insurance pays properly for the surgery, the cost of the laser surgery will be much less than the cost of a fusion. Now, everybody's insurance is different. Some people have a $1,000 copay or deductible. Other people have a $5,000 deductible. Some people even have a $10,000 or $20,000 deductible. What a deductible is basically the insurance company saying, if you have this surgery done, you, the patient, are going to have to pay $10,000 or $20,000 out of your pocket to have this surgery done. Now, why would a patient ever have to pay $20,000 for surgery? Well, there's only one reason. That's because the insurance company doesn't want you to have the surgery. So they're basically making you pay more, making it unaffordable for you to have the surgery. So you really think hard about getting it done. You see, once a doctor recommends surgery to 10 patients, if the deductible and copay, the patient responsibility was 0, all 10 patients would have the surgery because they want to get well. But when the insurance company starts charging a patient $1,000, $2,000, $5,000, or even $10,000, and I've seen plans now for $20,000 deductible. If the patient has to pay $20,000 and you recommend it to 10 patients, how many do you think will actually go through with it? One out of 10. So the insurance company is actually saving a lot of money because patients are deciding themselves not to have the surgery rather than the insurance company telling you not to have the surgery, which is what they want to tell you, but that would be bad for them because it'd be in the newspaper and then it's bad publicity. But the reality is basically they're forcing people not to have surgery by raising the patient's out-of-pocket costs, by raising copays and deductibles. This has been an ongoing problem for the last 30 years, and it's only getting worse. Every year I see insurance plans that pay less and less of the surgery and make the patient pay more and more. So What's the difference between ACDF and Deuk laser disc repair? Out of pocket? It all depends on your insurance. If you keep letting your insurance companies steal more of your money by not paying your medical bills and keeping it as profits, then shame on you. I can't fix the insurance problem of the country. I can fix back pain and neck pain, but I can make you guys aware the insurance companies are the problem. And the reason the insurance companies are able to make you pay so much for your own medical care, even though they're supposed to be paying for it, is because politicians in your state write laws that allow the insurance companies to raise your deductible. All of those insurance plans, health insurance plans, are regulated at a state level, not a federal level. Obama tried to regulate them at a federal level. Didn't work out. It helped a little bit, but it really didn't, because all the Obamacare plans had very high deductibles, and they were denying surgery for everybody that had Obamacare, making the patients pay a lot of money. So the problem, folks, is you. You have to get your politicians to fix the state laws so that insurance companies stop making billions of dollars in profit, and instead they use that money to pay for your surgeries. Next question. All right. I love it when people try to blame me for them having to pay more money for their surgery. It's not me, folks. It's you and your insurance company. So let's get it fixed so you don't have to pay so much. And by the way, it's not just me. It's everywhere. As a matter of fact, these high deductible insurance plans that people have, they're buying now because they're cheaper, they're actually having a cascade effect on hospitals, nursing homes. They're all going out of business because they don't have the case volumes anymore, because patients aren't paying for their surgeries, because insurance companies have made the patient have to pay more out of their pocket. So it's working for the insurance companies quite well. Every time a hospital goes out of business, that's one less place for people to go get well. That's one less place that will bill the insurance company after the surgery. Think about it. Hospitals have been closing. Denials for medical services have gone up. Yet, why has your premiums not gone down? The answer is obvious to me, folks. The insurance companies are robbing us blind. And the patients are suffering as a result. And of course, the providers are also suffering. But in the end, the insurance companies are making out like bandits. So wake up and do something about it. I can't fix it for you. You have to fix it. You've got to hold your politicians responsible and accountable to write state laws that block insurance companies from denying surgery, block insurance companies from denying medications that are recommended by your doctor, block insurance companies from denying, period, and block insurance companies from reducing what they pay your provider and raising your deductibles and copays. So people need to fight back. Otherwise, it's just going to keep getting worse. Thank you for watching. We'll be back soon with another Deuk laser disc repair.